This recording will go over Chapter 35, Upper Respiratory Disorders. The common cold is caused by the rhinovirus and affects primarily the nasopharyngeal tract. Acute rhinitis, acute inflammation of the mucous membranes of the nose, usually accompanies the cold. Acute rhinitis is not the same as allergic rhinitis, often called hay fever, which is caused by pollen or a foreign substance such as animal dander. Nasal secretions increase in both acute and allergic rhinitis. Symptoms of the common cold include rhinorrhea. So when you see rhino, the R-H-I-N-O, you should think nose. And urea, if you think of like diarrhea, we see urea flow. So rhinorrhea is watery nasal discharge, nasal congestion, cough, and increased mucosal secretion. The group of drugs used to manage cold symptoms include antihistamines or H1 blockers, decongestants, antitussives, and expectorants. The first classification of drugs we're going to talk about are antihistamines. So what is a histamine? So a histamine is a chemical mediator in the body that's responsible for causing the runny and congested nose that patients experience when they have rhinitis. So if histamine is part of the cause of the signs and symptoms that are unpleasant for a person with an upper respiratory disorder, an antihistamine can be the answer to helping to relieve those symptoms. So antihistamines are also known as H1 blockers or H1 antagonists, and there's H1 and H2 receptors. We're only going to talk about H1 receptors in this lecture. Antihistamines decrease nasopharyngeal secretions by blocking the H1 receptor. So the job of the antihistamine is to block that H1 receptor that histamine would normally bind to and cause the signs and symptoms that are unpleasant for the patient. Let's see here. So we got first generation and second generation antihistamines. So your prototype antihistamine is diphenhydramine. The brand name is Benadryl, right? Just so you can put those together. So diphenhydramine is your prototype antihistamine, and that is a first generation antihistamine. And the thing with first generation antihistamines is they have some side effects that can be undesirable. So most first generation antihistamines cause drowsiness, dry mouth, and other anticholinergic symptoms, whereas second generation antihistamines have fewer anticholinergic effects and a lower incidence of drowsiness, right? So our prototype drug, diphenhydramine, that's a first generation antihistamine, is going to have anticholinergic side effects. And when you think anticholinergic, what type of side effects are you thinking about? So if you need to pause the video and try to get your thoughts straight when we're going through these, please do so. But so anticholinergic, remember there's a couple of things you should be thinking. The two big things that you got to remember, drying and no glaucoma. So drying, remember it's anticholinergic, it's going to have that drying effect. Urinary retention might be associated with it. Blurred vision could be associated as an anticholinergic side effect. And again, drowsiness. So diphenhydramine a lot of times is going to make the patient drowsy. This is actually used as the medication in a lot of those like Tylenol PM type medications that have something in it to help the patient sleep. So anyways, first generation, drowsiness, anticholinergic side effects, right? And the second generation don't have as many of those undesirable side effects. Since the first generation antihistamines can cause drowsiness, we want to teach our patients that they should not drive or operate dangerous machinery while taking the medications. The anticholinergic properties of most antihistamines cause dryness of the mouth and decreased secretions, making them useful in treating rhinitis caused by the common cold. Antihistamines also decrease the nasal itching and tickling that causes sneezing. So let's look at diphenhydramine here, a prototype antihistamine. It is used to treat allergic rhinitis, the common cold, cough, sneezing, pruritus, and urticaria, and to prevent motion sickness. It works. Its mode of action is that it competes with histamine for binding at H1 receptor sites and antagonizes or blocks histamine effects. It has anticholinergic effects and should not be used by patients with narrow angle glaucoma. It could also cause urinary retention. So we want to use with extreme caution in patients with urinary retention. It is also contraindicated in patients with severe liver disease. Drowsiness is a major side effect of the drug. In fact, it is sometimes used in sleep aid products. The most common side effects of first-generation antihistamines are drowsiness, dizziness, fatigue, disturbed coordination, skin rashes, and anticholinergic symptoms such as dry mouth, urinary retention, blurred vision, and wheezing may also occur. Diphenhydramine can cause central nervous system depression if taken with alcohol, narcotics, hypnotics, or barbiturates. In terms of second-generation antihistamines, the second-generation antihistamines are frequently called non-sedating antihistamines because they have little to no sedative effect. In addition, these antihistamines cause fewer anticholinergic symptoms. If you look at your purple drug box, again, your prototype first-generation antihistamine is diphenhydramine. That's what you need to know. In terms of second-generation antihistamine, cetirizine and loratadine are your two second-generation antihistamines that I'd like you to be familiar with. So go ahead and pause the video, take a peek at your purple nursing process box for diphenhydramine, and pull out what you think is important from the nursing process box, and then resume the video. We'll see if we're on the same page. In terms of assessment, obviously we want to get baseline vitals, get a drug history, find out about any allergies, find out about any exposure to drugs or food or stress. We want to assess for signs and symptoms of urinary dysfunction, including retention, dysuria, and altered frequency, because again, with the anticholinergic side effects, it's going to make the patient prone to urinary retention. Note complete CBC or complete blood count during drug therapy, and assess cardiac and respiratory status. Nursing diagnosis, the big one, airway clearance, ineffective related to nasal congestion and sleep deprivation. In terms of planning, obviously, what are we hoping to see in the patient? They will have decreased nasal congestion, mucosal secretions, and cough. And in terms of sleeping, patient will sleep 6 to 8 hours per night, again, because that first generation antihistamine is going to cause drowsiness. Nursing interventions: give the oral form of drug with food to decrease gastric distress. Do not administer sub-Q. It's only oral, IM, and IV. In terms of patient teaching, warn the patient to avoid driving motor vehicles and performing other dangerous activities if drowsiness occurs or until stabilized on the drug. Advise patients to avoid alcohol and other central nervous system depressants. Let's hear. Encourage patients to take drug as prescribed. Notify healthcare provider if confusion or hypertension occurs. If taken for motion sickness, the patient should take at least 30 minutes before the offending event and also before meals and at bedtime during the event. Inform breastfeeding mothers that a small amount of the drug can pass into the breast milk. Advise caregivers that children are more sensitive to the effect of antihistamines. Nightmares, nervousness, and irritability are more likely to occur in children. So you might have heard people say before they wanted to give their kid Benadryl to knock them out in a flight or things of that sort. Sometimes they can have actually the opposite reaction where they do become irritable, and it can be actually more problematic for the parent. Inform older adults that they are more sensitive to the effects of antihistamines and more likely to experience confusion, difficult or painful urination, drowsiness, dizziness, feeling faint, and dryness of mouth, nose, and throat. We need to teach our patients they can use sugarless candy or gum, ice chips, or saliva substitutes for temporary relief of mouth dryness. Nasal congestion results from dilation of nasal blood vessels caused by infection, inflammation, or allergy. With this dilation, a transudation of fluid into the tissue spaces occurs that results in swelling of the nasal cavity. Nasal decongestants stimulate the alpha adrenergic receptors, producing vasoconstriction of the capillaries within the nasal mucosa. The result is shrinking of nasal mucous membranes and reduction in fluid secretion, or reduction of the runny nose. Nasal decongestants are administered by nasal sprays or drops, or in tablet, capsule, or liquid forms. Frequent use of decongestants, especially nasal spray or drops, can result in tolerance and rebound nasal congestion, rebound vasodilation instead of vasoconstriction. Rebound nasal congestion is caused by irritation of the nasal mucosa. The systemic and nasal decongestants that you need to be familiar with for exams are phenylephrine, hydrochloride, and pseudoephedrine. In terms of side effects and adverse reactions, the incidence of side effects is low with topical preparations such as nose drops. However, decongestants can make a patient jittery, nervous, or restless. These side effects decrease or disappear as the body adjusts to the drugs. Use of nasal decongestants for as little as 3 days can result in rebound nasal congestion. Instead of nasal membranes constricting, vasodilation occurs, causing increased stuffy nose and nasal congestion. The nurse should emphasize the importance of limiting the use of nasal sprays and drops. Your textbook has some different information about how long nasal decongestants can safely be used without risk for that rebound congestion. For our purposes, we're going to say decongestant nasal sprays can be used for a maximum of 3 days. So in terms of patient teaching, we want to say these nasal sprays can be used for a maximum of 3 days. And again, the teaching would include why not to go over 3 days, because of the risk for rebound nasal congestion, where it's just going to cause the patient more problems. As with any alpha-adrenergic drug, such as decongestants, blood pressure and blood glucose levels can increase. These drugs are contraindicated or used with extreme caution in patients with hypertension, cardiac disease, hyperthyroidism, and diabetes mellitus. In terms of drug interactions, pseudoephedrine may decrease the effect of beta blockers. Taken together with MAOIs, decongestants may increase the possibility of hypertension or cardiac dysrhythmias. The patient should also avoid large amounts of caffeine because it can increase restlessness and palpitations caused by decongestants. Now we'll talk about intranasal glucocorticoids. So glucocorticoids is a classification you're already familiar with. When you think of glucocorticoids, hopefully you're thinking anti-inflammation. So intranasal glucocorticoids work by decreasing inflammation, and as a result of that decreased inflammation, the patient will have decreased rhinorrhea, decreased sneezing, decreased congestion. The medication you need to recognize as an intranasal glucocorticoid is fluticasone. Again, it's ending in the SONE, so that alone should let you know I'm dealing with the glucocorticoid. Fluticasone's brand name is Flonase, if you're familiar with that one. These glucocorticoids may be used alone or in combination with an H1 antihistamine. The spray should be directed away from the nasal septum and the patient should sniff gently. With continuous use, dryness of the nasal mucosa may occur.